If you could please take your seats, we'll get ready shortly. Thank you.
Hello again, if we get you guys to return to your seats. So I think now in at least 2 or more of the former earlier presentations, you've heard the importance of the transformation of physician practice. So it's now my pleasure to introduce a true expert in this subject, Russell Kohl, Dr. Kohl, from the University of Oklahoma, where I think you may still teach, but certainly where you got your medical degree. Russell is the founder of 2.0 Healthcare. Formerly, he had been with TransferMed. He's now with 2.0 Healthcare. The importance here is that 2.0 Healthcare is working with CAPG in a program we have underway right now to help our members transform their practices. We've got couple handfuls of groups that are involved in this program. I think Russell may refer to it. It's available to CAPG members. And as you can hear from our previous speakers, is so key and critical, really, to basically the success and the prosperity of our groups going forward. So very important stuff. Without any further ado, please take it over, Russell. Thank you.
All right, thank you. Wow, that's really loud. You can come down a lot. He's not listening. He's the only person who can't hear me. All right, we'll use this one. How about that? Can you hear me now? I'll warn you, my degree of ADHD is such that this will be really entertaining if I have to stay behind a podium. It will involve bouncing side to side and all sorts of fun stuff, but we'll see how that goes for a little while. Thank you very much, Don. And so, as the presentation's gone on today, I kind of looked at it at the beginning, and it seemed like we started almost with a view of the globe, and then came down to the horizon, and then came down to the forest, and then came down to the trees, and really, the level of my talk today is at the leaves. We're at the leaf level of discussion. Amy talked a little bit about her background. I'll tell you a little bit about how I got into this sort of work. I was a rural family doc. That's what I trained to do. That's what I absolutely love to do. Had a solo practice in rural Oklahoma for 7 years and was ecstatic. Did all the rural family doc stuff, delivered babies, did my own C-sections, assisted on the surgeries, did nursing home, did all that sort of stuff. And one day I looked around because I got an email from a classmate in residency who was quitting practice. And I could not fathom how in the world somebody could leave something that was this awesome. Only 7 years out of residency, and it just made no sense to me at all. And I started looking around and seeing how many of my classmates actually were burned out. And I was even more confused. And so I took my day off a week and I started just going and following them around their practice to try and figure out why I was happy and their life sucked. And I found out that it turns out it's not actually rocket science. It's just if you're on the hamster wheel, you can't always see that you're on the hamster wheel. And having a different set of eyes from the outside sometimes actually made a whole lot of sense of what you were doing. Did that for about a year or two, and it turned out that the University of Oklahoma had an interest in their residents actually going into practice and remaining in practice. And so they asked me to join the faculty, where I rewrote the practice management curriculum for both the internal medicine and family medicine departments, and stayed on the faculty there and thought, this will be great, I'll do this forever. And there is a certain degree of institutional inertia in academic medicine that doesn't work well with ADHD sort of people. And so that worked out great for a couple of years, ended up actually going to be the chief medical officer at TransferMed, which was a subsidiary of the American Academy of Family Physicians. It was the group that actually did the original research around patient-centered medical home. And so in my role as the chief medical officer, I actually got to deal with all of the things that didn't make sense. So as our practice coaches would go out and work with practices across the country, if the formula worked, I never got to talk to them. If the formula didn't work, or if this group had a unique situation or something that was odd, that was what I got to go work on. And I can tell you that's one of the most exciting things to get to do, is to go all across the country doing that sort of troubleshooting. So As that company was actually wound down, we picked up where the work was and continued on with a number of the staff at 2.0 Healthcare. We've been really excited to work with CAPG ongoing and work with their members across the country to try and really take this from the big academic level and boil it down to the actual practice level. There's a couple of sayings in the military that always kind of jump to my mind when I'm talking about practice transformation and that sort of stuff. One of them is that no battle plan survives first contact with the enemy intact. Everything that you have planned is likely to change once it gets down to the clinic level. The second idiom that I think is really important to always keep in mind is the story of the lost nail. Everyone knows the story, for want of a nail. So for want of a nail, the shoe was thrown. For want of a shoe, the horse fell. For the horse falling, the messenger fell. For the messenger falling, the battle was lost. For the battle lost, the war was lost, all for want of a nail. It's those little things that you never thought about when you were designing the plan that come up and make it so hard at the end. And what I can tell you is that the interesting thing, when you get down to the practice level, think about all the material that you've looked at and you've learned today and you've contemplated today. Who's actually implementing that? This is going to be implemented by a 19-year-old with a high school diploma and maybe about 6 weeks of additional training. That's where your system exists. That's the person who is the face to some of those patients that you have. We've talked about an awful lot of complicated systems today. Those people are completely capable of doing this, but we have to think about it from the perspective of the staff and from the perspective of the physicians if you want it to actually be effective. So because of that, we wanted to talk today a little bit about how you get everyone on the team to actually practice at the top of their license, recognizing some are not actually licensed, but at the top of their skills and capabilities. So if you look at the statistics around physician burnout, this is not a local problem. This is a national problem. This is a huge problem. And if you step back and look at what are the things that actually cause physicians to be burned out, you'll notice all of those that are circled have basically nothing to do with medicine. Those have to do with administration. It's administrative tasks. It's the issues around, I have too much bureaucracy, I don't have enough time with patients, I spend all my time entering things into the computer. It's great that you have these HCC codes. Do I really have to go to the third digit of ICD-10 to make sure that I've documented this right? I used to see 20 patients a day. Now I can only get through about 8 to 10 a day, and you're mad at me because I'm not working any more efficient than that. None of those are things that people put on their application to medical school that said, why do you want to be a doctor? And they said, because I have a true shortage in administrative paperwork in my life. What would really make me happy is if I could do prior authorizations all day long, and I know that without an MD, I can't sign those forms, so I got to do it. That's not what people got into this for. And so what that leaves us with is physicians who look like this. And I can tell you that whether you're an IPA, whether you're an employed group, it doesn't matter. If your physicians look like that, you're not going to succeed. How many of you from a leadership perspective have ever tried to make physicians do anything? I loved the cat herding earlier. That's one of my favorite videos. That's what telling a physician to do something is like. And so you may employ them, and in that case, telling them what to do when they're your employee, frequently the kindest thing they can do is just get mad and quit, because what they're more apt to do is to just not quit and do whatever they want, which is kind of what we're good at as physicians. That's a special class in second year. But the reality is the physicians have to buy in. Everything that we do around practice transformation is easily plotted out on a comparison of competency versus commitment. If the physician, the staff, the practice, the leadership, if they don't have the commitment and the buy-in to the belief that this makes sense and I want this to work, the competency is irrelevant. I can teach competency. Ignorance is resolvable. Apathy is not. And so In many cases, that's where it starts. And if you think back to the leadership discussion this morning, if you want to deal with physician burnout, the first thing you have to have is their commitment to the idea that what we're doing now doesn't work. And doing the same thing over and over again and expecting a different result is the definition of what? Insanity. So you have to have that commitment from them. Once you've got the commitment, then we start working about the competency. If you think about the things that actually caused that physician burnout on the previous slide, those weren't tasks that require a medical degree, by and large. And so one of the things that you've got to look at about how you're actually going to implement this and make things work at the physician practice level is with team-based care. This only makes sense even if you step back from all the medical aspects and think about it from a pure business perspective. How successful is a business who uses a $200 an hour employee to do work that reimburses at $10 an hour? It does not require an MBA to recognize that that's a really poor use of a resource. And so in team-based care, what we try to actually do is understand what the tasks are, separate those tasks to who is the appropriate person to do them, and let everyone do the things that they're actually competent and qualified to do. We know for a fact that it's not possible for a physician to provide all of the preventative services to their patient panel. It's not physically possible for a physician to do that. Depending upon the study, you'll find it takes anywhere from 18 hours a day to my favorite is 26 hours a day is what it would take. So unless you're the Beatles and you get an 8-day week, it's not possible for you to do this as the physician. We also know that because of that, our patients only get about 55% of the recommended care. Now, this isn't 55% of all care. This is the care that we actually have evidence that is good. I would assure you, we spend a lot of time doing things that we don't have that good of evidence on. But we're leaving 45% of the stuff that we know works. We're not getting it done because we don't have the time. And then the last is 50% of a physician's time is spent using their medical knowledge, which means one of two things. Either we're using them incorrectly or medical school is twice as long as it needs to be. So when you step back and think about, okay, what really is team-based care then? This is really the definition that I find most useful to me. It's a model of healthcare delivery in an office practice setting that utilizes the individual staff members functioning at their highest level according to credentials and competencies. I want to emphasize that last line because a lot of times when organizations look at team-based care, they forget the bottom part, the and competencies. Simply because somebody has credentials that say they are allowed to do something or it is legal for a non-credentialed person to do it has no bearing at all on whether or not they have the competencies to do it. And so part of developing a team-based care protocol within an office is identifying the additional competencies that people need and how you're going to provide them. Training is a really key aspect of this as we move forward. So Amy was laughing that I'm a history nerd, and that's okay. But I had to look up the history of medical assistants. Just off chance, anyone here a medical assistant? MA? Okay, no. I did not realize they didn't exist before 1978. I didn't know. There's always been MAs while I've been in the office. But the reality is, according to the national records, until really about the 1990s, there was a doctor and there was an RN, and that was what the office staff was. There may be clerks or those, but it was a doctor and an RN. And it was only really at that point across the United States that as costs were being ratcheted down, that RNs moved much more into just the hospital, and the office practices were filled with LPNs and with medical assistants. Do you think that that was done in a really well-designed fashion? That somebody stopped and said, what are all the tasks that an RN is doing in this office? Let me catalog those tasks, and let's look at what really needs to be done. Somebody looked and said, oh my God, we're not going to make payroll this month. How do we design a system that we can lower the expenses here? And what are the things that it's legal for them to do? And in all probability, there were tasks that used to be accomplished in ambulatory care by RNs that we've forgotten they even did, because no one kept up with that. You can see the actual technical definition from the American Association of Medical Assistants, the formal definition of what a medical assistant is. Allied health profession, whose practitioners function as members of the healthcare delivery team, performing administrative and clinical functions. Team. They were never designed to operate independently. They were designed to be part of a team. And the interesting thing is when we go into a lot of practices don't really operate as teams. They operate as independent cogs, and sometimes those gears actually mesh into each other, but a lot of times they're completely unrelated. If you think about it, just from a purely logic standpoint, this isn't particularly rocket science. You stop and you look and you see, okay, why would we want to have a team? Well, first off, can the patient ever really be the center of care if the whole team is designed around the physician? No. If the patient truly is the center of care, there are things around that patient that the physician does not need to have an interaction with. Interactions that need to come directly from somebody else on the team to the patient and back. And the physician may need to be remotely aware of or understand the policy or understand the procedures, but the truth is they don't have to be involved in that interaction. And if we have a team that's based upon the physician being the center of that, you can never get to that degree. It becomes a game of telephone around the patients. The provider's actually free to practice medicine. One of the things that I did learn, and over the years I've had the opportunity, the last time I counted, I've been to at least 2,500 different practices and been able to observe how they do things. And one of the things that I have found in talking to physicians is, you know what makes them really happy? Practicing medicine. They love sick people. I know it sounds odd, but you give them somebody who's sick and they don't have to do the paperwork. They don't have to worry about, am I going to get paid for this? They have to make the sick person better. That's what they went to medical school for. You can see the light in their eyes. Think about every physician you've ever talked to who went on a medical mission trip. When they come back, what do they say? Oh my God, it was great. There was cholera everywhere. You know, that's what they want to do. Now, I'll throw this out to you because I don't think a lot of people think of it this way. We think about the physicians. How many of you ever stop to think about why people go into being an MA or an LPN? Because I'll tell you, it's the exact same thing. Nobody goes into nursing who says, you know, I'd really like to be bossed around and have instruments thrown at me today and you know, do some paperwork. What I really want to do with my life is call in refills. Refill clerk, that sounds like an awesome job. That's not what nurses want to do either. That's not what MAs want to do. And so if you are able to actually use the team and use people for what their skills and their training are, not only do you have an improvement in physician satisfaction, but you have an improvement in the rest of the staff's satisfaction too. Have you ever walked into a place where one person was really happy and the rest of the team was miserable? You may have once or twice, but you don't do it for long. You can't be surrounded by miserable people and remain happy. And that's what happens in many of our practices. The staff are more engaged. The patients actually receive more attention because there's not this gatekeeper role for the physician. And we actually know that costs decrease and revenue increases. Now, how many of you, your practices are in an APM? So in some sort of a capitated model? Everyone? How many of your physicians believe that? Because this is always the fun question. I deal at the system level about what we're going to work on, and then I go to the practices, and my staff and my team works directly with the physicians. Most, even really advanced groups, most of them still pay their physicians based on RVUs. Your physicians are not in an APM the vast majority of the time. That's a really interesting impact, because the whole reason this was designed was what? To influence physician behavior and productivity, and yet it's not always actually filtering down to the patient or to the physician level. And I think that's actually a really important thing as we look at how you move forward. In a lot of the IPAs that we work with across CAPG in different areas too, they still operate in a relatively fee-for-service world. A good portion of their patient panel is still in that model. One of the things that we know about team-based care is that because of the adjustments in the fee-for-service model to look at things like your transitions of care codes, your chronic care management, the Medicare annual wellness visits, in an average family physician's office, in a pure fee-for-service environment, there's generally about $250,000 left on the table at the end of the year that they just didn't capture because they weren't using their team to accomplish those transitions of care, that chronic care management, and those sort of items. And you may look and say, well, why does that matter? We're trying to transition them into an APM. The skills that they have in order to do that are what will make you successful as an APM in an ACO environment. The practices that are really good at those transitions of care and that chronic care management ongoing, those are the ones that will be some of your highest performers. I like to think in analogies. If you've ever met anyone from Oklahoma, we always think in analogies, and half the time we speak in them. And being from the South, football is the most common analogy for everything. So if you'll forgive the analogy, have you ever seen a team where half of them thought they were playing football and half of them thought they were playing basketball? That does not work out well at all. And yet, if you go into an office, a medical office, it's not uncommon at all for the clerks to be playing one game, the practice manager to be playing another game, and the physicians or the clinical staff to be playing a completely different game. And we expect this to be functional as a team. That makes no sense whatsoever. There's this artificial divide that came up at some point in medicine about clinical and non-clinical duties. Is there such a divide? I would hold out to you that if there's something that doesn't impact patients that you're doing in your office, you probably don't need to be doing that. So think of it from that. Every task in that office needs to feed back to how we're providing better care for patients. If we're doing it just to fill out the form and we can't show that that form makes something better, then that's the challenge for the team to actually look forward. You've got to have that clear goal and clear mission. If everyone in the office can't tell you what it is, what game they're playing, and how they're trying to win, you're not going to get there. The next is systems. Detailed clinical and administrative systems. I know there's a number of physicians in the audience. How many physicians have had the glorious experience of having the same nurse for at least 5 years? How many of you don't have to tell that nurse what to do at least half the time? Why? Because they've been with you. They know what you're going to do. You're comfortable with them. You know that they're not going to go too far. They're comfortable with you. They know that, she's pregnant. She said burns when I pee. He's going to want a UTI or a UA. Let me go ahead and draw that. We don't all need to sit and wait on the doctor to sign it. Okay. How does a new nurse get that experience? Because if you design clinical systems that actually consciously make those relationships between the physician and the staff, you can build that 5 years of trust in about 60 days. And suddenly you have a highly efficient team. Otherwise, you've got somebody who's got to work with this doc for 3 or 4 years, and we all know it'll get to going really well, and they'll do something completely off the wall, or they'll catch me on a bad day and I'm grumpy, and we knock ourselves back 6 months on that relationship. I'm not necessarily a huge fan of job descriptions. I know all the administrators go, oh. As soon as you try to write down everything that somebody does, invariably you leave things out. I love in the military, every job description everything ends with pursuant to the needs of the Air Force. All of it's flexible. When you're actually working with a team-based care, you've got to approach it from that. Everyone on the team has to be flexible pursuant to the needs of the patient. But you've got to develop those administrative systems. Outlining a clear division of labor. I love family physicians. I am a family physician. We suck at this. To get a family doc to give up anything that has to do with a patient is like pulling teeth. I may hate it. It may be just, but there's a certain degree of ownership and commitment to this patient that says, no, I need to do this. And so one of our favorite tools that we do when we first go into practice and we're first working with them, we have these worksheets that we give out to all the staff that say, please mark all the things that you have done in the last 60 days. And it's just all these different tasks. And it is a blast to watch the physicians fill it out, because they fill it out with glee. Oh, I've done this, and I've done this, and I've done this, and I've done this. And they get into a competition, and you get to the end and say, okay, how many of you had 30 things? How many of you had 50 things? And, some doc in the back stands up and goes, I've got 72. And you look at them and go, there are 9 on this list that require a medical license. That division of labor has to be clear, and it has to be explicit. And you have to understand that. If you're going to divide labor, though, like we said at the beginning, certification and competency are 2 different issues. And so if you're going to have somebody do something, ideally, you need to have some training for how they're going to get there. You can't do just-in-time training for everything. So as you're developing that division of labor and you identify these are the tasks we need an MA to do or an LPN to do, then you're able to actually look at what training they need and provide it in an organized fashion. Not medical school, see one, do one, teach one, but how do you actually do this well? And then the last part is communicating effectively. Be it protocols, be it face-to-face communication, teams don't function without communication. How many of you know your practices all do a minimum of a 5 to 7 minute huddle every morning with their care team? That's the most effective thing that team can do to make their day actually go forward. There's great evidence, and I can show you the templates actually of how you have that. And if the meeting's longer than 7 to 10 minutes, it's too long and you have lost all efficiency. Now it's an admin thing and no one's listening. But about a 3 to 5 minute huddle in the morning, think about the small practice model. When I was in solo practice, I never realized I was having a huddle, but every morning I walked in and I had my nurse and we looked at the schedule real quick and said, okay, I've got to go to a play at school at 2 o'clock. I will be back at 2:45. Don't put anything in that slot, and I am walking out the door at 2 o'clock. I don't care what happens, so let's fix up to there. This person's on the schedule. They've no-showed us the last 6 times, so you need to call them 30 minutes before, and if they're not here 10 minutes before and somebody else is, go ahead and put them in that slot. And, oh yeah, John just got out of the hospital last week, and I haven't seen the discharge summary. Call and get that before they're here. You can increase the efficiency of a primary care staff exponentially in 5 minutes just by having a planned care throughout the day. But that requires that sort of effective communication. I thought this was really funny. I saw it in a presentation a number of years ago. One of my team members uses this a lot. Hope is not actually a plan. So when you talk about diabetic care and our chronic care of diabetics, and you say, what do we want to accomplish? Well, we hope that they get an A1C quarterly. Hope? Is there not some sort of a system? Is there not an order to be written? How do we do this? The greatest one there that I've always been amused is, we hope that they get a finger stick at each of their visits if they fasted, and we'll just kind of guess and go from there. If you're leaving things to variability, then variability will reign, and you will never get to the outcomes that you're looking for. So let's step back from that and say, what is it that we're actually trying to accomplish? First off, I'll argue that I don't think a diabetic needs a finger stick at every visit anyways, but should the physician who is treating them believe that that's the protocol they're going to use in their office, great. Let's talk about how we're going to get that done. And if we're not going to get it done more than half of the time, let's talk about the expectation of why we're doing it. Because if we're doing it less than half the time, we're not doing it anyways. Let's use that time for something far more efficient. So because of this, I spend an awful lot of time, and my staff spends an awful lot of time, doing workflows. How many of you have done like Lean Six Sigma sort of training? Woohoo! How many of you have walked into a practice and they said, oh, thank God, my dot wimp is completely out of control and I need you, yellow belt. Please come fix my waist. No, it doesn't really work that way. It's a tool that can be applied. The other thing that I think is really critically important that I see in a lot of people who have training around Lean Six Sigma, but don't necessarily have the real clinical implementation experience is look at the patients that come into your office. Look at the parts that come into a Toyota factory. Look at the variability between the patients that are coming to see you and the variability of brake shoes that go on a Toyota Corolla. Lean Six Sigma is not designed for the degree of input variability that a primary care practice has. Doesn't mean it's not valuable, doesn't mean it's not a great tool, but a lot of times we go in and we try to approach it and take a very strict step. I trained in the Dartmouth Clinical Microsystems model as a medical student and truly believe that that's a far more efficient model and it's a far more flexible model, but the tool of Lean Six Sigma becomes very important as we look at those workflows. So, as we do this at a practice level, we talk about standard work. Yes, there are lots of different ways to take care of this patient. We in medicine live in a gray area a vast majority of the time. A lot of times there's not a black and white answer to what the right answer is. There's not a specific wrong answer. But sometimes there is. And if there is a no kidding black and white, how do you take a blood pressure? There is a best way to do it, believe it or not. There is a protocol for how to do it. Maybe that's something we should standardize within the office. Maybe how we weigh patients is important. How many of you have ever seen the patient with the incredible fluctuating weight depending upon which nurse is on duty today? Congratulations, ma'am, you've lost 6 pounds. Yeah, I know, I didn't carry my purse today. What, you were holding your purse last time? Well, yeah, it's okay because I had on my Uggs too because it was really cold and the parka. So, I probably did lose weight anyways. This is standard work. And yet, we laugh and it's so obvious. And yet, go observe a practice and see how frequently that sort of variation actually does occur. So once we identify the standard work so that we can make sure that what we know is right gets done every time, then we identify who actually does it. Does the doctor need to be the person to check the blood pressure? What do you think? Yes or no? Doctor should check the blood pressure. Yes, raise your hand. No, raise your hand. Who said sometimes? You win. So you don't need to be doing the screening blood pressures. Good God, you have a staff. They're quite competent. They can check blood pressures. If it's weird, you might want to actually check it yourself before you begin therapy on a patient based on a lab test. I was always trained the first reason for an abnormal lab is because the lab screwed up. Only after we have ruled out that error do we consider that there might actually be something wrong with the patient. Trust but verify. Same with things like blood pressures, finger sticks, those sorts of things in the office. So step back and think about this from a workflow perspective. Before the visit, somebody's getting to the office, but they're not here yet. What is it that we actually need to accomplish? Does the patient just walk into the office and everything goes? That's one of the real challenges for those of you who have urgent care. You don't always know who's coming in today. And so that can be a real challenge, and that's a really fun workflow to go through on the side because that requires efficiency of infrastructure that you don't always have to have at a primary care office. It's great to have it at a primary care office, but you can get away with a certain degree of not great infrastructure if you have a known patient panel and I know who's coming in tomorrow and I can work around that. If I don't know who's walking in the door 5 minutes from now, the infrastructure looks incredibly different, has to be far more efficient. We know that things like health maintenance, what information is needed for follow-up, those are all key aspects that if the patient gets here, we're just going to be sitting doing nothing until those things are actually accomplished. The clerk receptionist greets the patient. How many of you have waiting rooms? How many of you have done the sneaky trick? I'm sorry, we don't have a waiting room. We have a reception area? Anyone? Okay. Who has silos? No one has silos anymore. There are no silos in medicine. We have cylinders of excellence. Call it what you will. If the patient is sitting there waiting, it's a waiting room. And that is a waste of time. It's a waste of your time. It's a waste of the patient's time. And so as you work through that workflow, what is occurring that's making them sit there? What is the waste in that situation? It may be that there is a real need that, no, this person must just sit here and wait. There are critical aspects that are occurring at this point. Awesome. What can we do with them during that time that's going to take away time from somewhere else? Anyone have a shortage of educational materials for patients? You think, you know, one of my biggest problems is my patients are just far overeducated about their disease process. I wish they didn't understand the pathophysiology of hypertension quite so much. I know they have hypertension. I know they're sitting right there. They're staring at a wall. I don't even have to have good patient education materials to get them to look at it. It just has to be better than staring at a blank wall. If you actually have good patient education materials, think about the outcome. They actually, have you ever had, and I've only had this happen once in my career, and I was really ecstatic, so go out to call a patient back, and the patient goes, just a second, I'm watching this, and this is really good. We had PowerPoint slides on a video monitor in the lobby, and the patient was like, no, I've always wondered about this. Just a second, I got to watch this. That's pretty awesome. I now have a patient arguing with me about the prioritization of their health. We're not arguing about, you know, did Dr. Oz say this or that? No, this is valid information. Awesome. This is the kind of training, you know, this is the kind of day that I trained for. Let's have this discussion. So looking at that sort of waste becomes really important. Swim lane diagrams. Everyone's favorite thing. I almost put the picture up here, but I didn't. I don't know if any of you know Jay Lee, California. Jay's awesome. Jay took a picture one time of his office doing a workflow design. It was a wall at least a third of the size of that wall. And if you're doing a workflow, you know what the best tool in the world is? Post-it notes. And they had that entire 8-foot-tall wall covered in Post-it notes, identifying everything that happened in a visit, everyone who touched the patient. And they did their workflow by walking over and going, why are we doing that? Somebody would say, well, it was part of the research protocol 4 years ago when we were on that project, remember? Are we on the project now? No. Does it bring any value? No. Congratulations, that's not on the workflow anymore. Using that sort of a model and then tying it back to a swim lane diagram allows you to stop and create that workflow in an easy way. One of the things that's key about practice transformation that we've learned is don't explain to practices how you're doing it. They don't care. They don't care what tool you're using. They care, is my life getting better? How much time am I spending for this, and is it worthwhile? And so being able to take that swim lane diagram and say, okay, doctors, here's all the things on yours. Any of them you don't want to do, move it to somebody else's list right now. It causes a land run towards the wall to move things off. It's a great tool, and it's something that, interestingly, one of the speakers earlier today commented, there's a huge challenge in implementing universal policies. There's no such thing. No such thing. You can't take any procedure out of one clinic, pick it up wholesale, and move it into another one. It may be theoretically possible if I get to move that entire staff. The floor design is exactly the same. All the supplies are in the exact same place, and the same patient shows up. I would argue at that point we have crossed into the twilight zone, and it is irrelevant how this works. So what we actually have to do is look at this particular practice. How are you doing it here? Because if I try to implement the same rule in a practice that has 3 exam rooms per patient, that's being used in an office that has 4 exam rooms per patient, we just put in a variable that's going to change the entire workflow. So we look at things like before the visit, when you're actually rooming the patient, what are the things that the nurse or the MA or the care manager, what are the things that need to be done? And then, once the patient's roomed and the provider's in there, what is the provider actually doing? I'm going to pause here for a split second and throw it out just because this is an interesting debate that we have had at every client that we have worked with, is the role of medical assistants or medical scribes. Every system has this debate. And it's very interesting because I believe it was Thomas Jefferson who once said, very smart men given the same information will often come to differing conclusions. That's exactly what scribe use is. Very smart people with good intentions are given the exact same information and come to differing conclusions. I can tell you that the thing that tends to be the deciding factor in those discussions is what your ultimate belief about the role of the medical record is. Systems that believe that the purpose of the medical record is documentation for purposes of billing and quality improvement take that away from doctors. They say, it turns out that doctors view medical records as the documentation of what I did today, not for medical legal purposes, but so that when they come in next time, I know what they looked like today, I know what I did, and I know what I'm planning to do next time. If you approach it that the purpose of medical records is solely for medical treatment and planning, then you tend to leave it with the physicians. The challenge of that, which of those pays more? I mean, the good news is my presentation only involves addition and subtraction. There is no sine wave equations or anything that you have to know. But this is one of those basic math sort of deals. Which of those, based on the presentations you've heard today, is going to make you more money? And that becomes the challenge for systems. And then it becomes a return on investment argument. In your particular market, how much is it going to cost for you to have a scribe? What's the efficiency of the scribe? What are the medical legal ramifications in your particular state of using a scribe for documentation? And you get into that. And so this is an area that I think is really important because from a workflow perspective, that changes the workflow dramatically, but not necessarily in a positive or a negative way. It's just different. So I put this up here. I have, there was the swim lane diagram that we used earlier. This is just a very basic time task map. So these are the sorts of things that we do with practices all the time. In this office, it was a really, it would frustrate me, let's say that. The physician was spending basically 41 minutes per patient, which is awesome because what's the average? The average is like 46 seconds or something like that physicians actually get to spend with patients. But in this one, the problem is, I'm spending 41 minutes, but I'm doing a lot of stuff that, why am I the one doing medication reconciliation? No one else can read the names of the medicines and make sure that they're still, are you taking them? Patient and family social history. Those things are very important as they relate to the chief complaint and as they relate to your treatment now. If we're doing a wholesale gathering of fill out the survey and complete all the check boxes, that's probably not necessarily a great use for the physician's time on an ongoing basis. And so when we actually looked at this particular practice, like I said, the physicians were spending about 41 minutes per patient, including documentation, which was 6 minutes, which I thought was actually pretty impressive. I don't know that I could document all the stuff that they were doing in 6 minutes, but they had gotten it down really well. Do some basic math in your head. If it takes you 41 minutes to see a patient and you plan on being at the office less than 24 hours today, how many patients are you going to get seen? How many patients are you going to get seen per hour? What's your physician's hourly rate? Do those two things make sense? Can you make profit at the end of the day, or we should have started off as a free clinic because as we are, we're going to be a negative clinic? So in this case, what they were comfortable with, and that goes back to the other thing. There's not an ideal. There's what you're comfortable with and what is appropriate in this practice. We were able to get them down to 22 minutes. But the key was the MA took over. Instead of doing, okay, weigh, okay, do your blood pressure, okay, sit here, the doctor will be in. We built into that process, okay, let's look at your bag of medications because you bring all your medicines in a paper sack every time. Let me compare these across what's in the EMR. Wait a minute, what's this one? Where did you get that? Have you seen any other doctors? Did you have any surgeries that you're just hiding from us, anything like that? They took care of that, and the physician now, 15 minutes of their time was no kidding working with the patient. So now 15 of the 22 minutes is what the physicians value. Before it was 15 of 41 minutes. Now, you can argue 15 minutes is still not efficient enough for me. And, okay, that's fine. We can debate what your cost, return on investment's got to be for your physician staff. But making that simple adjustment to the team and to the workflow based on how you use your team was a huge issue. And now, the thing that I will point out that makes this so important from a CAPG perspective is work after clinic or WAC is a huge problem. Physician satisfaction is a huge problem in all of the systems that we've worked with. Truthfully, I've been very surprised how difficult staffing is, not at the physician level, but at the MA and LPN level for many of the CAPG members that we work with. Many of them are in a market where it's actually really hard to get MAs, and that's a very competitive market. These are the sorts of things that allow you to retain staff instead of have to turn over and train new staff. That satisfaction becomes a really critical aspect. After the visit and discharge, as we break it out, you can workflow through each of these. Talks a little bit about the different times that they're sitting in the reception area and how you might be able to use that differently. There are a lot of things that are effective in between visits. We don't always have to have the patient in the office to take care of them. And if you don't have a workflow for those sorts of things, then it becomes haphazard, and haphazard involves things getting lost. The two most common causes for malpractice litigation against family physicians in the United States, anybody know what the top two are? One is failure to diagnose, delay in diagnosis. Those are the two things. I have a friend who's a malpractice attorney who says, no, there's only one cause, and it's they're mad at you. But the medical aspect is failure to diagnose or delay in diagnosis. Most common reason in both cases is you ordered a test and never got the results. Either the test didn't get done, the results came back and they're sitting in a file somewhere and you didn't see them, and by the time you saw them, oh crud, she's had cancer for 3 months and no one's told her. Those are problems. Those are problems that can be fixed by a workflow. But if we only design workflows for the patient in the office and not for their comprehensive care, then you don't actually have a system of care inside the office. And so we spend a lot of time doing that sort of work. We end up breaking out. Like I said, I don't particularly like job descriptions, so this is the closest that we tend to get. And then we let the HR people create whatever they want, and we'll ignore it. That's okay. So I think it's really important as I come to a conclusion here. If you want to use a team-based care, you have to first off be very deliberate about it. You can't just walk in and say, hey, guess what? We're going to do team-based care, so I'm not doing any of this anymore as the doc. You guys, good job. Go team. No, that's not how teamwork works. You don't just show up for the Super Bowl having never developed any plays or practiced how those plays go. And so if you want to get to that level, the very, very first thing you have to do is understand what it is that you want. If you're thinking that you want to enhance the role of medical assistants or enhance the role of LPNs or adapt the role of RNs within your system, the very first thing you've got to do is understand what you mean by that. Are you wanting them to be in more of a care coordinator sort of role? Are you wanting them to be much more of a team partner sort of role? So as the patient comes in, they basically glom onto them and pull them through the system with continuity. Are you wanting more of a health coach sort of role? These are all, if you don't have that idea at the beginning, it's very, very difficult to redesign the system. So in conclusion, because of the audience that we have here, I think it's really important to step back and, you had a whole lecture on leadership. There's really only 3 things you have to do as a leader, 4, that you have to do as a leader to really support team-based care. If it's an area that you want to go to within your practice, the first is you have to create that shared vision. Shared is the key word. Your vision is irrelevant. Our vision is what actually gets implemented. And so if it's your vision versus our vision, you're not there yet. Don't try and do anything else. Stop. Until you have a shared vision, you're not going to effectively move forward. The second is maintain open communication. Communication's everything in team-based care. Communication's everything in leadership, in my opinion. If you're not able to have that communication, and the most powerful words I've ever heard a leader say were, I'm sorry, I was mistaken. If you can't have that discussion with your practices, you're not there yet. We've got to talk about the relationship that you have, because until there's that level of vulnerability and discussion back and forth, we're not really transceiving, we're just transmitting. And then the last is identify and remove barriers. One of the things I was taught as a young officer in the Air Force was that your job as an officer is to get all the stuff out of the way that keeps the sergeants from being able to do their job. As a good leader, at the system level, your most important role is to identify the barriers to that individual practice and practice manager being effective and get those barriers out of their way. Because if you can remove those barriers and they're still not effective, then the problem lies with your selection of leadership below you. You've got to be able to get the barriers out of their way and let them go. So you establish buy-in at the site level, going back to the very beginning, competency versus commitment. I can teach most anybody to do most anything, but if they have no commitment to it, Amy likes my goofy saying, you can't teach a pig to dance. It just wastes your time and annoys the pig. We've done that in practices before, where the healthcare system has said, no, I want you to work with this office. You're going to go in and they're going to show up. Yeah, that's a great situation as an educator to walk in and go, I know you're all miserable and don't wish to be here and hate everything I stand for. Let's have a great day. That doesn't work. You got to build that commitment at the beginning. Establish that training infrastructure. Use guest speakers. Bring in people from the outside, ideally practitioners from the outside. Don't bring in experts. I know that sounds really weird because supposedly I am one, and don't ever believe anyone who says they're an expert about anything. When you're talking to the practice, credibility doesn't come from degrees. Credibility doesn't come from accolades. Credibility comes from, I've done this, and I am doing this, and I screwed it up more times than you can imagine. And here's why I'm here to help you, because if you're going to try this, let me show you the 8 or 9 ways that don't work first so that you don't have to repeat those. And you can get that by bringing practices together. And most systems are not one practice. You've got 4 or 5 at least. Pick a really good one and a challenging one, and hopefully there's some friends and they'll talk to each other. Use that mentoring relationship ongoing. And then finally, getting that training. Put this up here just to show you, in our small groups, we play a lot of games. I'm a scoutmaster in the Boy Scouts, and so I have a limited amount of time that I can remain seated, and that's why I've stood at the back most of the day. One of the things that we do a lot is we play games. So, to give you a quick demonstration, this is our fun game. Name that staffer. So what we do with this frequently, we'll sit down with the team, and here, we'll play a game for a second. So the question is, what staffer is legally allowed to accomplish this particular task? And so let's see, we'll start off with, this is always my favorite. Draw up a vaccine. Who is legally allowed to draw up a vaccine? If you believe an office clerk is allowed to draw up a vaccine, please raise your hand. If you believe a medical assistant is allowed to draw up a vaccine, please raise your hand. If you believe an LPN is allowed to draw up a vaccine, please raise your hand. RN, NP, PA. Oh, you're not even putting your hands down anymore. This is part of the exercise. It gets the blood flowing. MD, DO. Anything else? Physical therapist. You know, the bad news? It varies by which state you're in. So I can tell you, actually, in most states, an MA can draw up a vaccine. That is not true in California and New York specifically. I know the law in those 2 states, and actually I know in Pennsylvania too. Can't do it. The interesting thing is they can administer a vaccine, but they can't actually go draw it up and put it in the vial. So that gave away one other. Here, we'll do one other just for fun. Manage a patient phone call, non-triage. Okay? So what do we mean by a phone call non-triage? We mean, hey, this is Lucy. I need a refill on my, well, let's go with Lortab, because everybody calls and asks for Lortab. So this is Lucy. I need a refill on my Lortab. Who can handle that? Can the clerk handle that? Clerk handle that. Okay? MA, LPN. Okay, everybody above LPN RN. Okay, so what do you think? This is a trick question. So I do have a handful of trick questions. It's a trick question because what do I mean by handle? So yeah, the clerk can write it down and the clerk can forward it to somebody. Depending upon the state laws, in a handful of states, actually the clerk can't take a message of a medication unless they have had additional training, because they could miswrite what the medication is. They have no training in medication reconciliation. This becomes really important in a lot of states because a lot of us ask our clerks to take notes and don't give them any training or recognition on drug names. So it becomes important as you're working with the practices to know those individual names. So this is a lot of how we do stuff. I really appreciate your time, but the good news is that's the end of the day. So I'm more than happy. I will be around if you have any additional questions or comments. So I'll take any now if you want. And we have 0 minutes worth of questions. So if you need anything, I'll be right around here. Feel free to grab me. Otherwise, thank you. I think it's been a great conference today.
I promise I'll let you get out of here soon, but not before. You do one thing for me. So you should have surveys on your table. Please, 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 pretty please, with a cherry on top, fill out your surveys. The doors are locked, so you will not be able to leave anyway. No, I'm just kidding. But see, Diane's moving to the door, so she and Laura will be collecting the survey. So we really do appreciate your feedback. Please be frank, please be candid as to how we can best serve you and serve your needs. So I know some folks need to get out of here, so I am just going to keep going while you're filling out those wonderful circles. So I wanted to give you a slight preview for October. This is what we'll be having for our October agenda. Symposium still here, same place, Chicago. We have our esteemed colleague, Mariella Cummings, who's sitting in the back, who had great, great questions for us today. She will actually be leading the conversation on resource use, utilization. We have our great friend from NCQA, President Peggy O'Kane, coming, and she'll be talking about performance measurement, about HEDIS and STARS. We'll also have Steve Valentine talking about the challenges within an integrated delivery network, a clinically integrated network, coordinating between hospital and group. Also, we have two kind of contracting topics, one with Catherine Bowen on stop-loss insurance, and then finally, Matthew Mazziani will talk about finance, accounting, and solvency requirements. Those of you who don't know who Matthew is, he actually was on the executive team at Healthcare Partners. He was their CFO. So he really knows, if anyone knows anything about contracting and finance solvency, it's him. So if you are trying to start up your own risk-based model, I really do recommend that you attend our next symposium, October 27th. The complimentary webinars, they're of course free, and you're welcome to sign up. It's on our website. These are the topics. So in June, we've got Dr. Mai Pham from CMMI. She'll be talking about current things going on, and I'm sure she'll touch upon the regs that are out and how they affect the next-gen ACO. Also in September, we have CEO Stacey Harantis from Sharp Steely talking about patient satisfaction. And then in December, we've invited Grace Diaz from Anthem, talking about compliance and delegation oversight. So really, as a risk-based entity, as a physician organization taking on all the delegation, what do you need to know to pass the audits? And then 2 plugs for our annual conference. I know all of you will be there. It's in San Diego, sunny San Diego. How can you not come to San Diego in June? We have a great conference planned for you. You can read the people there, Jay Geller, Dr. Chandra, Dr. Berenson, and Scott Blakeman will be there. And we've got a great agenda in terms of the breakout sessions and the plenary sessions. And then finally, we have our colloquium. It'll be our 3rd annual colloquium in DC. So we really do try to stay current with policy and really show up where CMS and the policy wonks and the staffers are and really help lead the country and move the country into this movement, into value. So we'll be there September 28th through 30th at the colloquium. So if you haven't gotten the message today, join CAPG if you're not a member yet, and we will continue this movement together. So thank you very much for coming. We value spending the time with you today.